Hey guys, okay, today we are going to take a look at chapter 14 after we finished up in the previous chapter with how nurses are involved in the clinical diagnosing of infectious diseases. In this chapter, we want to take a look at that pathogenesis of those infectious diseases, meaning how are they spreading? How are they getting, we understand again from the chain of infection, how it goes from one person to another, but here we're going to specifically talk about these pathogens and how themselves are pathogenic. So let's take a look and let me show you what I mean. All right, let's get into chapter 14 here. All right, start from the beginning. Here we go. Chapter 14, we're looking at, again, pathogenesis of infectious diseases. So in this chapter, we're going to take a look at, we'll see an introduction. We're going to take a look at the terms infection versus infectious disease. There's a real small difference between the two of them, and I'll show you exactly what I mean by that. And why, in the difference between the two, why sometimes an infection doesn't always occur. Let me show you what I mean. There's 4 periods or phases in the course of an infectious disease. We'll take a look at the terms localized versus systemic when it comes to diseases. You might be able to tell based on those terms. Local means one area, right? Very similar to what we're going to talk about with diseases. Acute versus subacute and chronic. We'll see briefly the difference between the terms signs and symptoms. As I mentioned in the last chapter, oftentimes those terms are used together. They're used synonymously, which means that, oftentimes we see them using them hand in hand, but there is a slight difference between the two of them. We'll bring up the term latent again. We actually saw that earlier in our class, but we'll see that again as we are discussing infections now. We'll see primary versus secondary infections. We'll talk about the steps in the pathogenesis of infectious diseases. We're going to be real brief with that. I'll talk about the term virulence, meaning that kind of what makes infectious diseases, what makes them cause infection. So what are their virulence factors? I'll show you what I mean. Okay, so introduction to this chapter. So the term path refers to disease. We've actually brought up the term path pretty often as we've talked about pathogens, right? Because again, those are germs, right, that cause infection, or microbes that cause infection, as opposed to non-pathogens. Pathology is the study of diseases, right? So pathologists working in the laboratory, as we discussed in our last chapter, those are the ones who are working to help to diagnose these diseases. So here we're going to see that term path again, or that prefix, in the term pathogenicity, which means the ability to cause disease. So these microbes that are causing diseases. So pathogenesis refers to the steps or those mechanisms involved in the development of that disease. So an infectious disease, here's what we're going to talk about when I mean infectious disease versus infection. So an infectious disease is a disease that's caused by a microorganism, a microbe. And the microbes that cause that infectious disease are again collectively referred to as pathogens. So we have discussed that a little bit already. Infection is commonly used as a synonym for infectious diseases. So such as an ear infection is actually an infectious disease of the ear. But here's why they're actually slightly different. Microbiologists are actually going to reserve the word infection to mean a colonization by a pathogen, which means that the pathogen has made its way into your body and is starting to spread into your body. However, the pathogen may not always go on to cause that infectious disease, meaning I may be exposed to influenza, right? I might sit next to somebody in class and they cough on me. But for a number of different reasons, that may not turn into the flu for me. It may make its way into my body, meaning that the infection has occurred, so I'm infected with the flu virus. However, I might not get sick from it. And that could be because I have already had the flu virus this year, or perhaps maybe I've had the vaccine, or maybe it's that I touched something that person touched, and well, this is a little bit different. I won't get infected because I wash my hands. But in the event that maybe I've had the vaccine, it may not go on to cause that infectious disease. So it's a little bit different as far as the difference between those two terms. So a person can be infected with the pathogen, but not necessarily have the infectious disease. So on the next slide here, we talk about, they actually did that very thing that we just talked about on the previous slide. So whoever, the book publisher who created this slide used the term infection where they probably should have used infectious disease. So an infection has occurred, but why are there possibilities for the infectious disease to not occur? That's what they meant to say in that title there. So one, the microbe may land at an anatomic site where it's unable to multiply. So it gets onto my body or into my body somehow. But if you guys remember when we talked about viruses and then even a little bit with bacteria, there's receptor sites that these pathogens are looking for that match up perfectly. So there's little kind of like a lock and key mechanism that if it's not in the right spot, it's not going to be able to meet with that receptor. Many pathogens must, what I was just mentioning, many pathogens must attach to that specific receptor site before they're able to multiply and cause damage. So again, therefore, they won't if they're not at the right site. Antibacterial factors may be present at the site where the pathogen lands. Perhaps I just use hand sanitizer and, or perhaps maybe I, touch something and then I used hand sanitizer. Again, these are different factors that may be present. Or perhaps even indigenous microflora. So the next bullet point says that the indigenous microflora that again normally live in and on our bodies, they actually are there normally, and they are going to fight for the right to that site, that's where they normally live. So they may inhibit the growth of that foreign microbe. So that's again an example of microbial antagonism, if you remember the term antagonism. The indigenous microflora may produce antibacterial factors. So again, for the same reason that the indigenous microflora are like, hey, this is where I live, this is my house, you don't belong here. So they're going to somehow try to fight off that new microorganism. The individual's nutritional and overall health status sometimes influences the outcome of the pathogen host encounter. Could be that the immune system is really great and has the ability to fight off that pathogen before it develops into an active illness. The person may be immune to that particular pathogen. Again, that could be for a number of different reasons: previous exposure, vaccine, just genetics gifts that the genetically gifted that they have that immunity. For a number of different reasons, people can be immune to different diseases. Phagocytes present in the blood may destroy the pathogen before it has a chance to evolve or before it has a chance to spread. So here's what happens. The 4 periods or phases in the course of an infectious disease. What happens, there's the incubation period. So that is where, we've been exposed to the pathogen makes its way into our body. That pathogen's kind of just hanging out right now. We don't feel any signs and symptoms of anything, but it's there. Then we get into the prodromal period. If anybody, knows that when you've been sick, sometimes it starts really small. Maybe you start getting a little tickle in your throat, something's on its way. So that's what we're feeling as in terms of signs and symptoms. But in our body, this is what happens with the pathogen. The incubation period first, and the prodromal period, which is the period just right before the actual period of illness. This is when, the prodromal is kind of when it's beginning to start to spread. The period of illness is when we notice that it has started to spread. It has started to spread, and now we start developing those active signs and symptoms. We are kind of in that active stage of that illness. Then there's after that period, again, depending on the type of illness, if it's a virus that we just have to wait it out and let our immune system kind of do its job. Sometimes there's medications that have to be taken before, we can get rid of that illness, whatever it may be. But then we get into the convalescent period, which is our recovery period. At that point, we may not be fully recovered. We do start to feel better. We start to, move around a little bit more, again, depending on the disease itself, but we still have some pathogens still present that are on its way out. They're being destroyed by the immune system or the medication that we're taking. So again, that's kind of the recovery stage there. So as you can see from our diagram here, depending on that illness and the severity of that illness, we either enter into the convalescent period, which is, again, that recovery, or again, with really severe infectious diseases, Depending on how they've taken over our body, it could lead to disability or even death. So hopefully neither one of those are the case for our patients or ourselves, but that's the phases in the course of an infectious disease. So let's take a look at a couple different terms when it comes to infections. Depending on the type of infection, we have what's called localized versus systemic. And this is what I was talking about in the outline to this chapter, that these terms may already be a little bit familiar to us. That localized, we know when something is local, we stick to one area. Infections do the same thing. So once an infectious disease is initiated, the disease may remain in one particular area, and that's going to be called localized. Or it may spread to other parts of the body, and that's where we're going to get into systemic. Examples of localized infections, some really great examples that we're probably pretty familiar with: pimples, boils, and abscesses. We know that when we get a pimple, it goes right there. It stays right there. The only time pimples typically spread is just sometimes when we get other ones, when those other pores tend to clog up themselves. Or sometimes sometimes people say that if you pop a pimple, that if it spreads onto your face, then what's inside of that pimple could go to other pores. That's the only reason why that would, become something that can spread. But pimples don't spread from your face to your feet, something like that. They don't spread throughout the body. So that's going to be a localized infection. Whereas systemic infections, these are going to be more severe, as we've seen that term systemic before. When an infection then spreads throughout the body, it is then called systemic. Okay, so systemic, like miliary tuberculosis, that particular infection is going to be something that spreads throughout the body. It is definitely going to be much more severe. Some other terms when it comes to diseases: acute, subacute, and chronic. And if an infectious disease comes on really quickly and leaves very quickly, it's called acute. So it's something that's kind of small, like a cold. A cold quickly comes on very rapidly, leaves very rapidly. So that's what it means there. An acute disease: rapid onset, rapid recovery. So examples would be measles, mumps, and even the flu, influenza. Whereas chronic is the exact opposite. Has a very slow onset, typically lasts a very long period of time, if not for the rest of that patient's life. So tuberculosis, leprosy, and syphilis are examples of chronic diseases. We do have some diseases that are kind of in between, and that's where subacute comes in, where maybe the onset is a little bit more, it's a little bit faster than the chronic disease, but less suddenly than the acute. So the big thing to remember here from this slide is acute versus chronic. All right, the difference between signs and symptoms. So again, oftentimes used hand in hand. A symptom, though, is going to be something that is a little bit more subjective. So meaning that these are things that are typically experienced by the patient. Things that typically, as the nurse, we can't see these things. So aches and pains, ringing in the ear, blurred vision, nausea, dizziness, these are all things that the patient can experience, but we can't really visibly see those on the outside. They can tell us that they're experiencing pain. They can tell us that they're experiencing nausea, but that's not something we really can see. I mean, unless they start vomiting, of course. But that is going to be, and that's why it's called subjective, because it's something experienced by the patient themselves. Oftentimes, that's the reason why we ask patients to measure on a scale of 1 to 10 their pain level, because then it allows us to give some type of measurement to that symptom. When you see the term symptomatic versus asymptomatic, there are different types of diseases. In a symptomatic disease, a patient is experiencing symptoms. But remember what happens, like for instance, when we talked about latent infections, and we'll bring this up again in just a second. Sometimes there are illnesses that can or diseases and pathogens that can kind of hide from the host immune system, causing the patient to go into an asymptomatic stage. So asymptomatic means without any symptoms. And there are some diseases where the disease itself doesn't have any symptoms. So that's what I mean by the term symptomatic and asymptomatic. So the opposite, or not the opposite, but comparing to the word symptom, a sign is going to be more objective, which means this is going to be something that we can actually measure as the nurse. So for example, like an elevated blood pressure, abnormal heart sounds, these are things that we can actually pick up. Laboratory results that come back from the lab, we know this, we can see this with our own eyes, again, as opposed to the subjective symptoms. So that's the difference between the two. So again, I mentioned with latent, the only reason this is brought up again, because we just talked about the term symptom. So again, when something goes from asymptomatic to symptomatic and then asymptomatic again, that's an example of a latent infection. They can go again from a patient displaying these different symptoms. They can, they feel this illness, and then they go to asymptomatic and then back and forth again. That's an example of that latent infection. If you remember, we talked about how herpes is a great example of a latent infection. All right, let's talk about the terms primary versus secondary. So a primary infection one disease may sometimes lead to another disease. In that event, the first disease is referred to as the primary infection, and the secondary disease is referred to as the secondary infection, which makes sense. So a great example would be cases of bacterial pneumonia frequently follow behind just a mild viral respiratory infection. The reason being, when a patient has a respiratory infection, if that patient, sometimes that's something that we can wait out, but in the event that it goes untreated and it becomes more severe, sometimes those pathogens can make their way down into the lower respiratory tract and build up, some more pathogens and become more serious. So the primary infection in that case would be that very mild viral respiratory infection. The secondary infection would be that pneumonia. So during the primary infection, as I mentioned, the virus causes damage to the ciliated epithelial cells. Remember, those are our cells just on the inside of the respiratory tract. Cilia, if you guys remember, our trachea is lined with those tiny little hairs that kind of work in like a sweeping-like motion, because the idea is to keep things out of the lower respiratory tract. So they're working to try and make sure that we cough things up that don't belong or swallow them down into our throat. So that makes its way to the stomach. Causing that damage to those ciliated epithelial cells, these cells are then unable to clear those opportunistic pathogens from the respiratory tract, and therefore leads to that secondary infection. So that's the difference between primary and secondary. Okay, so once again, the steps in our pathogenesis. So we talked about kind of what happens on the human end. We see that the incubation, prodromal phase, and then we have that period of illness, and then it leads to the convalescent stage. In the pathogenesis of an infectious disease, what happens is the pathogen enters into the patient's body. The pathogen then attaches itself to some tissue within the body. The idea is then for that pathogen to then multiply. Once it starts multiplying, it begins to spread and then invade the host body. So it evades the host defenses. So it's able to hide from the host immune system, therefore then causing damage to the host tissue. So that's the steps that we see in that infectious disease process. So when we see the term virulent, virulent is oftentimes used as a symptom for pathogenic. It means if a pathogen is virulent, it typically is something that is definitely going to lead to an infection of some sort or infectious disease of some sort. So there may be virulent strains of a disease, or of a pathogen. Of a microorganism. So again, meaning that it's pathogenic. And there are some strains that are avirulent, which means non-pathogenic. So they're not going to lead to an infectious disease. So virulent strains are capable of causing disease, whereas avirulent strains are definitely not. So there's an example down here. You don't have to be familiar with that specific example. Big thing to know here is the difference between virulent and avirulent. Like I said, very synonymous with pathogenic and non-pathogenic. So sometimes the term virulence is used to express the degree or measure of pathogenicity. So again, for example, sometimes, as it mentions here, it only takes 10 Shigella cells to cause shingillosis, but it takes between 100 and 1,000 salmonella cells to cause salmonella. So therefore, Shigella is more virulent than Salmonella because we need a lot more of those pathogens in order to lead to that specific infection. So sometimes that term virulence is used to measure, that virulence itself. Okay, or again, like I said, the degree of pathogenicity. So what makes a pathogen virulent? So we have what's called virulence factors. And I think we've talked a little bit about this. I know we did with bacteria, things like pili and capsules that bacteria possess that helps them in their, process of being a pathogen. So that's what that is. A virulence factor are attributes that enable these pathogens to be virulent, essentially. So they help them to attach, escape destruction, and cause disease. So virulence factors are these phenotypic, which means just visible characteristics that are dictated by the organism's genotype, which means their genetics. So for instance, some bacteria have what's called adhesions. So these are special molecules on the surface of these pathogens that are considered to be virulence factors because they allow them to, just as the name kind of implies, it allows them to adhere to the host. So they allow them to recognize and therefore then bind to the host cell receptors. So just as, again, we talked about that, again, these pathogens are looking for this kind of lock and key mechanism. They need these receptors to attach to. It's the adhesions on the pathogen that's going to attach to those. Then there's pili. Pili are also, we mentioned pili when we talked about bacteria. They're kind of like little spikes on the outside of this bacterial cell. They enable them to attach as well. So kind of similar to adhesions. So here's an example of the adhesions on the outside of this virus. And then on the host, you can see the different receptors that line up with those adhesions. Okay, and here's an example of pili. Like I said, they're almost like little spikes on the outside of this bacterial cell here. And that too is going to help them to adhere, making them virulent. Okay. I tell you what, you guys, let's skip over. Yeah, let's skip over. I meant to take this off your PowerPoint. The obligate intracellular pathogens and the facultative intracellular pathogens. Let's not worry about those. Let's go to the rest of these virulence factors. Capsules and flagella, which we've already talked about with bacteria, they too are also going to be considered virulence factors because capsules are, again, on the outside of bacteria, almost acting as like a shell. And therefore, that's going to be considered a virulence factor because it's protecting them from phagocytic cells that are going to work to destroy these bacteria. But instead, that's going to protect them from that immune system. And then flagella is considered a virulence factor because if you remember, flagella gives bacteria the ability to swim. So it's going to move and hopefully then therefore escape destruction by our immune system. So again, specifically these phagocytic cells or phagocytes, which are white blood cells that are going to destroy by eating these bacteria, but they're able to escape from that and also travel to where they want to, to get to start multiplying and causing infection. Okay, exoenzymes, we talked about this with bacteria. You do not have to know the specific types of enzymes, but remember, exoenzymes are toxins that are produced by bacteria. That's what they are. They're able to excrete chemicals that are going to help them to kind of cause harm to our immune system, making them even more virulent. So know what an exoenzyme is. And then toxins as well. Let's put them together. Toxins, these are poisonous substances that are released by different, typically different types, such as endotoxins and exotoxins, but you guys don't have to know the difference between the two. Just know that toxins are also something that can be excreted by these pathogens, making them, helping them to cause more damage. Okay. All right, guys, and I tell you what, let's, so this is going to get into why they can escape the immune responses. Let's see. Yeah, let's just talk about that real quickly. So antigenic variation. So some pathogens can escape the immune system by changing their surface antigens, which is, again, if you guys remember the term antigen, is what causes our body to produce antibodies. And those antibodies are therefore going to help to get rid of those pathogens. But sometimes they can kind of change the shape and what those look like, so that as our immune system is looking for these pathogens, we can't find them because they look different. So that antigenic variation. Camouflage or molecular mimicry. Some organisms can conceal their foreign nature by coating themselves with the host proteins. So they use the host, items and things in their body themselves. So it works as kind of like a camouflage. And then the destruction of antibodies. Antibodies are what our body creates in response to these foreign, invaders, but they can just some pathogens can destroy those. So some pathogens produce, not that you have to know it's called an IgA protease, but this is an enzyme that helps to destroy some of the host antibodies. You don't have to know the example. Just know that that's something that that's one of the mechanisms that pathogens can use to escape the immune response. Okay. All right, guys. So that's chapter 14. I know that's kind of short and sweet, but hopefully that helps you guys to understand the pathogenesis and how these pathogens are then causing infection in the body. As usual, guys, if you all have any questions, let me know.